So welcome here to the Value-Based Healthcast, a unique venture in Wales. And so value-based healthcare, this is how we can improve accessibility and outcome for the whole population, but within the same sort of envelope of funding, mindful of the impacts of health, including sustainability and on the environment. So it's a really quite a broad issue, and we have invited speakers today, and I'll leave Dee to explain a little bit more about that.
So hi everyone, welcome to the ValueCast. So today we're going to be talking about bone health. We have some fantastic speakers and presentations for you, but I just wanted to remind you that you can participate and get involved by using the Q&A button, and once the presentation's done we can have a discussion piece where we can actually raise those questions, think about what it means for us in our areas, in our value-based healthcare teams and right the way across Wales, and how we can really collaborate as well. So please do take that time to get involved. Nick, if you'd like to introduce Inda.
Yeah, but before that, we didn't introduce ourselves, because I know we're winging it at the moment. So I'm in Swansea, and I presume you're over at the Royal Glam, are you? Or where are you?
Yeah, I'm up in CTM.
And so did you want to introduce yourself?
Sorry, yeah, so it's been a while. I'm really pleased to be back. So I'm Dee Lowry. I'm Head of Value-Based Healthcare for Cwmtaf Morgannwg University Health Board, but also have the pleasure of working with all of my value-based healthcare colleagues across Wales as well.
And I'm Nick Wilkinson. I'm a consultant paediatrician based in Cav, but here today in Swansea at the Welsh Paediatric Society. So, and we have a lot of going on for value in peds as well. So really want to introduce you to Inda Singh, Dr. Inda Singh, who is consultant physician and geriatrician in Aneurin Health Board. He specializes in bone health, as Dee has mentioned, and he's national clinical lead for falls and frailty. Now, I reached out to Inda when I first started, and I think he had just been appointed, and I found then that I got really confident and compassionate advice from Inda. So I'm really looking forward to this, because I think it's going to be impactful. And what I know is that I'm not the only one to be impressed by Inda, because when there was the launch, I think, of the fracture liaison services by Jeremy Miles, he actually cited Inda by name, praising him for his dedication. And as Dee said, we've already, the National Value in Health team have already been working with Inda on his projects for high value impact pathway on bone health. And then we have Christina Martin as well, and Dee's going to introduce.
Yeah, we're delighted to be joined by Christina Martin, who's currently the Head of Business Development in the Value-Based Healthcare team at Aneurin Bevan. She's had less than 2 years experience with us, but more years than she apparently wants to declare in public sector. But she's been working with passion and drive to help us scale and deliver value. And the value team at Aneurin Bevan have really been working closely alongside Inda for a number of years on a variety of projects, including one about bone health that we're about to hear about today. So Nick and Christina and Inda, if we're ready. Inda, over to you and Christina.
Yes, no, thank you for the nice introduction and kind words. So we're going to just have a joint act between me and Christina, and I know I cannot thank everybody enough that how much you have supported and given this opportunity. And Christina and team has been amazing. And when I was sharing and meeting with them, they could actually change the vision and all the thoughts into reality. And I have thanked Christina several times for that, because I had an idea how to measure it, but Christina came together. This is on a paper and we can see it. So changing vision to an action is an art. And Christina, you did that as well. So I'm going to share that as well. So I'll just share my screen, and I'll start with my disclosures as well. And I'll just change this, I think. So my disclosures at the bottom, and it's the views which I share and which are from several individual colleagues, people, organization, third sector. And I have been sponsored to attend some work with the pharmaceutical companies, but there is no conflict. But this is the most important slide. And I think this slide tells us that why patients are so important. I highlighted them. They should be on the top of this. But it's the team working, it's that integration, the partnership, which is key to develop or implement any services. When we talk of the quality part or measurements, which we're going to discuss today, it's again, end of the day, is your team. And I'm very grateful to my own health board who have supported me throughout and the staff who actually trusted that we can deliver this. But if you go back a couple of years, nobody actually was thinking of the bone health. And I can bet many people today haven't respected their bones enough before knowing about the bone health in Wales. So I'm going to share why we need to respect our bones. The bones are living organs. And at the time of conception, bones are formed as our heart and lungs and liver are formed. And then gradually, few months, 9 months later, a baby is born, which has got bones. And we tell that baby to crawl around, go and get some sunlight, drink milk, and walk around. And few years later, we tell the baby to go out and jump around and develop your bones. Otherwise, you will not grow taller. But after puberty or adult age, we forget about that. And we forget there are a lot of hormones which actually are needed for the bones. But in addition to that, bones also support us. They make us stand tall. They protect our organs. They store your minerals, calcium, magnesium, everything. They help you to move, but they also give you a defense system, that blood cell production which we need. But this is all often being taken as granted. We are okay. The bones are okay. They will respect us. But we need to respect our bones more. And there is a hashtag for respect your bones if you like to see. But this is the next part of that. That's our policies, the government. And again, this is something we have to actually work around. But we are dealing with older adults. We're not dealing with elderly people. It's the language which we need to work on. And we need to understand the needs of the population are changing. And this is a very diverse group of community. Not everybody is going to break a bone. Not everybody will be frail and not everybody will be fall. Many older people or adults are actually serving the nation and community. And they are the one who are actually still giving us wisdom and ideas what to do next and what not to do, or avoid any mistakes. But that's where we have to change our stereotypical thoughts. And this is based on this guidance and the data what we have. Now, this is all Wales. In the last 50 years, we have grown, but we have grown successfully. It's a healthy aging which should be congratulating us rather than worries that we have a lot of older people. Without the good secondary prevention and good primary care and social care, we would not have achieved this. Every medicine we have, every intervention we do is always for the secondary prevention. But joined and married up with a good primary health, primary care, social care, it gives us this community which is aging successfully. So this is something to congratulate us and be proud of, not to get too worried about this. But that's a challenge. But it tells us why do we need to change? Yes, with aging, we'll see new problems. Now, this is the data based on the scope studies. It just tells us that we are all as a growing nation in the whole Europe. Some countries in the Europe will have more older people, more osteoporosis, but that's all there. But we have to face this, accept the challenge, and see how we modernize our services, how we deliver the care differently, and how we bring more value to what we deliver. That's the key part in this. So if we go back 10 years, every 2 minutes somebody was fracturing in the UK. And as we speak now, every minute somebody's fracturing in the UK. I like the BBC News, it's all good. But how we evolve on that news? That news is there to tell us how we need to modernize, how we evolve with that. Now in Wales, every year we're going to experience 20,000 fracture. Where is our evidence there? Yes, we have that. But what have we used that evidence for? So that data should be used to data to knowledge. And that knowledge should change our practice. Should we do things differently? Do we have to manage all those falls or should we prioritize something else now? Now that's where the value is. And on this note, I'm very grateful to the value-based team who have used and actually decided or agreed on that bone health will be one of the 5 value metrics in Wales. That was the great news when we had last year. So this is the patient journey. Now, when we see this type of fracture coming to our medical assessment units or front-end injuries, they go through this pathway. They get the multiple x-rays and everything else. With due respect to the surgical team, they're doing a great job. Front door, they're dealing with these pressures all the time. But at some point, they have offload this to primary care. And a primary care will have a whole patient approach, which is needed for the patient. And they provide the comprehensive person-centered care. And they think, oh, right, this person had fallen. Oh, they need that falls care plan now. And then they refer that person to assessment for the falls risk, the care repair, the bone health, the community team, the therapists, this has all been happening. But the problem is, naturally, we have got so many processes. And if this has taken so many weeks, we know we are going to fail. And this is what is happening in our falls services as we speak now. But the chances of this success is only 5%. This particular person with a fracture will be seen in 90 days. So at the outset, the processes are not right. So what we need to do is we need to think smart way of working. That fracture has happened. Why do I need somebody to tell me this fracture has happened when it's all in front of me? And this is what the CrimTough team is working on with us, that let's integrate with radiology, rheumatology, COTI, frailty teams. Let's pick up these fractures within days and then do things differently. So because fracture is seen as not just as a fracture, it's a warning sign. It's a warning sign something else is coming our way. And osteoporosis is a hidden condition. Now, prevalence of osteoporosis and diabetes is not very different. But osteoporosis have impact on older people. Hence, the loss of function, the physical dependence, or leading to frailty is much higher and quicker at a faster pace following a fracture. So, for example, the prevalence of diabetes as we speak today is 4.4 million in the UK. And for osteoporosis is 3.8 million. But the impact what is having on the community, on a hospital, whether it's a front door, community, everywhere, is massive. So hence we need to address osteoporosis, which has come to light. Until now, it was a hidden and a silent condition. And now we know, suddenly following our fracture, we have said, this is low energy or low impact, this is fracture, but now this is going to be a long-term condition. That particular individual who had this, they're going to live with that for the rest of their life till the last day of life. And again, the value team actually has nicely put that in way that how this should be considered as a long-term condition. So that's where we are with the problem. So I'm going to share how severe is this problem now to gain attention. And please don't hate me more if you're already hating me with so far. The problem is this. Once we have worked so hard in their life and we reach the age of 50, the lifetime of risk of having a fracture for every woman living in the UK is 1 in 2. That's a fragility fracture. That's how common it is. And this is preventable. And for men, it is 1 in 5. So I mean, and you can see the hip fracture incidence is 1 in 5 in women and 1 in 10 in men after the age of 50. So that's a very high risk. And this doesn't stop here. It's a problem that we do need to treat osteoporosis right now. And mostly whenever I go, the question comes, is it cost saving or a cost avoidance? Both the answers are yes to that, because each hip fracture costs us £26,000 a year. And that's acute cost, social care and community care cost. But I think we need to ignore this and think of the value part here. The value is that person's life is changed. And that particular person who's living with that fracture, they are going to live with that burden of dependency, loss of confidence, and fears of falling, loneliness, depression. Everything comes as a package following this fracture. And we have no way, the type of services where we can actually liaise with that particular person to understand the psychological impact of a fracture now. Now, this is not fall only. Fall leads to a lot of psychological depression, loneliness, but imagine the fracture. So that is the science behind it now. The science is telling me we need to act fast to de-risk the fracture risk. Now, this is telling us the relative risk of a next fracture. Now, if you look at the first year, the relative risk is showing 5 times higher. So which means if somebody has to have a fracture, that will happen in the first 12 months. Act fast, don't stop. And this is based on a multiple studies. And this is the Capture the Fracture partnership across the globe, which has got 192 countries participating in it. And every fracture, whether it's a spine, hip, humerus, forearm, everything is important because next fracture is on its way. And look at the hazard ratio so high, but it doesn't go away for next 10 years. It's going to stay there with that particular patient. Hence, the longitudinal care plan linking with the community primary care is essential when this person is identified having a fracture. So it doesn't stop. So I'm going to take the same journey for that particular one patient who is in the age group of 50 to 60. And if we don't do anything, what will happen? Now, this particular person hasn't got any medical comorbidities, not even hypertension or cholesterol. But after the time, they're having a recurrent fracture after fracture. Now, this is defined as accumulation of fracture-specific comorbidity burden over lifetime. So now this is fracture cascade. It's a spiraling effect of those recurrent fracture which is happening. And the reason I describe this as a spiraling fracture is happening in front of us. The radiologists keep mentioning, oh, multiple fractures of the spine. They had a fracture here. And we know that. Even patients forget to count the number of fractures sometimes because it just become a norm for them and they are having these fractures. But what is the impact on individual and us as a health and care providers? 50% of them cannot walk unaided. How will we provide care or support to these individuals? We don't have enough therapist support. Then mortality is very high. And if a mortality is high, that means as a nation, our healthcare facility is not right when we know we can do something. And a discharge to care home is 15% for following a hip fracture. We don't have so many care homes. But let's talk of the simple thing. And many of my colleagues have said actually, and they are the medical doctors, senior consultants, oh, this was just a vertebral fracture. My mom had a fall, it's okay. It's not okay because 2 in 3 patients will be complaining of chronic back pain. And they keep asking for help, whether it's a spinal surgeons, whether it's a GP or care of elderly team or social care. They're seeking help because they cannot manage that job. They require, say, 14 GP visits per year and still carry that or the risk of mortality. And then the further part of which is unmeasurable impact on these individuals, they stick to that chair. We have very clear goal 5 and goal 6 plans, avoid deconditioning, get the people more able, healthier rails. That's all part of this. They're living with that fear of falling and having another fracture. Now we go back to the bigger picture now, from one patient to hundreds and thousands of patients this time. Now, this is Canadian study, and they have 115,000 patients. And this is American study, which is 377,000 patients. And these two studies are going to tell us about the risk of future fracture. And we have several tens and hundreds of studies like this. So I'm going to simplify what these studies tell us. So let's take the story to Wales. In 2020, we had 20,000 fractures. And based on the data what we have, and at 1 year, if we do not do anything, we'll get extra 10% refractures. And if we don't do anything for 2 years, we get 18% refractures. And if we don't do anything for 5 years, which is coming to 2025 now, we'll get additional 31% refractures. So the simplest answer for this is that option of doing nothing is not there anymore. We have to do something different to reduce this spiraling cost. And we have seen that, and I have observed the fracture occurrence and prevalence for most health boards. I'm not going to say that we can just completely take all away and we can provide cost savings. The word is cost avoidance and avoiding that harm as a result of these fractures coming on those individuals. So can we avoid this refracture cost by using some medication? And that's what I alluded earlier to the preventative part using the medication. So exactly what we do for stroke, for diabetes, or any heart condition, we give them drugs, but we do have a non-drug treatments for that. My bones are no different than that. We give them a secondary prevention, and we give them non-drug treatment of like not to drink alcohol, no smoking, healthy diet, sunlight whenever you get it, and do regular exercise. But that's there. But we need to think about where are we with these drugs. Now, if we look at the red drugs, which is the fracture and osteoporosis drug, if you look at the reduction in the healthcare use is much higher as compared to many of the other medical conditions. The only condition which can beat us is stroke and blood pressure. So hence, I will never say, no to the blood pressure tablet, but it does help. But when we look at the x-axis, the cause of long-term care or institution is higher for fractures. So hence, in both ways, on a balanced approach is telling us if we need to avoid the long-term care and we need to have a reduction in healthcare use, please, we have evidence for that. And this is not from one study. Again, the tens of studies are telling us the story that these drugs are very effective and efficient. We have a systematic review early this year, which tells us every single drug we have, which is NICE approved, is better than placebo. Few drugs are better, but every drug is better. And this is based on millions of patients which has been involved in those trials. So do we have a standard recommendation? So this is where the ways is simplifying the matter. So simplifying things, we just identify these fracture, and the recommendation is 80-50-80 rule. If we identify 80% of rigidity fracture and we treat 50% of them and make sure 80% are adhere to those drugs, because we know most humans do not adhere to the medication. The compliance is really poor. So osteoporosis drug compliance is only 20% at 52 weeks. So again, that's something we need to work on. But if we have this 80-50-80 rule, and this is not my rule, it's coming after agreement for the International Osteoporosis Foundation and being adopted by the UK, that yes, that's a way forward for us. So that is what we need to identify and need to do. So I'm going to take you to the story of my personal team. What if we don't have this? What we feel? That's what the idea is that. Now, why do we have to work differently? And this is the 3 years only, that we have to have a very wider participation and integration. We need to educate our staff and executive members, and we need to see what are their issues. So my manager come and tell me, my main issue is waiting list for 6 to 7 months. Okay, fair enough. Let me do that. What does my team members feel? My administrators telling me we're just wasting our time. We are blamed. We are waiting because relatives are calling them, but they are feeling helpless because clinics are packed, because we're doing same thing again and again and not getting enough value for our time. The clerks and the directorate support officer is telling we have to change the clinical team. There's a hostile culture. When you ask the doctor, can you see more? Why? How can I see this? They feel we need to respect what they feel. The radiologist said, why do I bother mentioning word fracture when there is nobody there to act on it? What's the point for me writing every report? And again, the radiologists are saying they're not being valued for what they're doing and reporting the DEXA scans. But we need to think about all these views as well, that how the staff is feeling. And that doesn't help sometimes. But it was a very positive move. We came together and we thought we'll do something different. So this is just the final part of or the second last final. That we work together, we said, let's start identifying fracture, and we come to a conclusion very gradually that we can see everybody above the age of 65 and over. And we respectfully ask radiologists to please report the word fracture, and we have to reassure them, and we'll work with you, and we'll pick up this patient and see how we go. So in this report, there could be patients who had no fracture, there could be old fracture, it could be high trauma fracture, but we need to separate that. But working within our team and everybody do the right job, we can go in more detail into this part, but that get us to identify those 60 patients out of 189 reports who actually had a low trauma fracture in a week. So that's my workload for a week for this service. But that's the standard part of any services where we need to have a high value impact. So we are not at the first part of prevention yet, and we are working with Public Health Wales. But the part of early accurate diagnosis, we have that, we identify. We optimize the intervention, which is the bone health treatment, and we provide the supported treatment for 52 weeks. And we have that all in place. And then finally, you go to the long-term care. But again, we're not ready for that yet. But that's again the part of quality statement. But the only thing which we ask is how to measure that we actually have PROM and PREMS part, and which Christina is going to talk more about that how to measure value. So when we have got a clear science and a database, which is a national database to see which direction we're going. Now, this is what happens. It's a story where 13% is me, where I continuously do false bone health clinic, nothing changed. Until you get a nurse for a day working with you, and you can offload a lot of different work. But when you get a coordinators, another full-time nurse, you see that you identify more patients. But showing this graph to the radiologists, they feel happier about it. And this is the non-spine fractures. You achieve that 80%. And it cannot be wrong because fracture has been reported by radiologist and it has been put it on the national database. But how you achieve that over time by getting it. So we sorted one problem only, that we identify the problem, but we haven't treated it 100% correctly. But we worked more closely to identify the vertebral fractures. Now, people do get surprised how this identification is more than 100% because denominator is fixed. So denominator for AB is expected fracture is about 750 in a year. But if we identify 1,000 vertebral fracture, that's why it will be 150%. So that's the difference because it's the audit driven data and that will go above because denominator is fixed. So, but you can identify more vertebral fractures, but see how we change with the age. Let's make it more 75, more 65, word fracture, expand to CT, MR. You actually identify more of the spinal fractures, but spinal fracture burden in women is massive. It gives them pain. And again, it's not very well addressed. And it increased the workload of spinal surgeons. And as we speak today, for my own health board, there were 6,700 spinal fracture referrals. Out of them, if 10% are fracture, that can easily be offloaded. That's what I see as a value in the services and working and benefiting cross-divisional. So that's the next part. Once we identify, can we adhere to the treatment? Can we give that treatment to them? But we are not achieving above 50% yet. And this is where we requested the 6 goals and a value team and a Welsh Common to help us more because we need more resources. So the results are showing better because we have put a third nurse in, but still its time will tell us. So we are somewhere in June as we speak today in these graphs, but you need more staff. Once you identify, then you treat. But having that extra staff clearly does an improvement. So ABFLS team, what we see as an example, you are above the national team already. So national benchmark is still at 25% and you're reaching 50% by just making the small change. But required staff member for this service is 4.7 nurses. But if you have a full complement, we can achieve 80% on this as well. Now, that's a lovely picture which Christina has put it in. And I'm going to pass to Christina from here on, but I'll move the slides, Christina. But why do we need to do this collaboration with a value team? So Christina, you take over and I'll go on mute.
Oh, thank you. Well, so I'm going to, my bit's nowhere near as exciting as Dr. Singh. So I'm going to talk to you a little bit about how value have got involved with this. So in Nine Bevan, we have a clear value-based healthcare strategy, which talks about how we measure and act, not just measure, but act upon what matters to the patients in Nine Bevan. So PROMS is one of the tools that helps us do that. It helps us see what matters to our patients. Okay, but PROMS is a part of value-based healthcare. There are other aspects of value that we're doing. Won't talk too much about those today, but case mix variables, our activity data, our theatre time that we're not using on hip fractures, etc. All of those aspects, including costing, are all being done as well. But I'm going to focus this slide on our patient-reported outcomes. What we worked with Dr. Singh to look at, what is it he's trying to find out from his patients? He's trying to find out what matters to them and how we measure to be able to act upon that and make changes. So one of the things that was important, I know Dr. Singh's talked about it, is the quality of life with patients. They often report anecdotally that they lose their confidence, etc., when diagnosed. So that was really important, and we chose a quality of life which is fairly universal. It's nice and simple, patients like it, called EQ5D, so we included that. There were some experience measures that we needed to include on the service so that we could report and make changes and tweaks to how the patients felt going through the service, because their outcomes and their experiences are very different things. You can have excellent outcomes and a poor experience, and vice versa. So we need to measure both. And then the other thing we included was a lifestyle optimization, which was a tool we was a brainchild of our cancer services team, actually, which we helped them develop. And what that does, it offers immediate, almost immediate responses to some lifestyle optimization questions: food, mood, movement, smoking and drinking. 5 big factors that affect bone health, but they also affect other health conditions. But Dr. Singh thought that that was quite pertinent for the cohort, because the questions we ask around food, for example, are an indicator. It's not perfect, but it's an indicator to a patient's nutrition daily, how much fruit and veg they eat, how much processed meat. Well, that can impact on their bone health. So as a service, knowing that, at the moment, we think with our pilot, it's around about 60% of the cohort so far in our pilot have indicated not great nutrition. So that might help the service develop going forward. We also offer automated, it's a fully automated system. They say, for example, I smoke 20 cigarettes a day. We ask the question, do you want help and support to reduce or quit? They say yes or no. If they say yes, we get an automatic referral to our Help Me Quit team, our cessation team within Public Health Wales. So they get those immediate support for some of the lifestyle optimizations, which is unique to us at the moment. So that's interesting. So that little diagram at the bottom shows our pathway for our PROMs. And again, this was developed in conjunction with Dr. Singh and the team. So they identify a patient through that automated response check-in for the word fracture in radiology reports. Once those have been identified, the system, we've automated it, so it's not very resource heavy on staff, to send a message to the patient with a link to complete a baseline PROM. So we do that before they have any interaction with the fracture liaison service, and so that gives us a good baseline on their quality of life and what they're doing and how they're feeling. Then we do it again after they've a couple of weeks, 2 weeks after their first appointment. In that, we include some experience measures. Did they feel valued, listened to, etc. And then again at 2 key points, which are following key interaction points for the other key process measures and the key performance indicators. So after 16 weeks, we ask the patient and we follow up with their quality of life and some experience measures. And in that one, we also include the medication compliance, because as Dr. Singh mentioned, medication compliance is that's about where we start to see it fall off, and it's really important to maintain that. So we try and reinforce that through the PROM that the patient fills in themselves. And then again, after 52 weeks, we ask all the questions again, so we can see for each patient, as well as on a cohort level, whether they smoked before they had interaction with a service and whether they've still smoking now, whether they've reduced the amount of cigarettes they smoke, whether they've reduced their alcohol, whether they've increased their fruit and veg. All of those things, as well as the quality of life measures, their anxiety, their pain and movement, their usual activities, can they still look after themselves as they did? All of those things we can see for every single patient individually, but also then on a cohort level, which is what's really important for us, that we can see what the patient looks like. And within that, we've also got some demographical information that we can layer in to show geography and things like that. Does that have an impact on the patient's outcome? So these are all self-reported by a patient, sent to them automated. I think I've talked enough about that one, Dr. Singh. Can you just change? Thank you. So this is just a screenshot of the platform we use currently to send and receive our patient-reported outcomes. So this is based on the pilot we've done. As you can see, the 237 is on patients who should have been or have been identified as needing a FLS PROM. Out of the 237, we sent 178 notifications. Now that's because the difference, my math is not great, 50 something, didn't have telephone numbers or email addresses that we could send the information to, because it's a digital form. That's something we're working on. Out of the 178, 72 people completed, which gives us a completion rate of about 40%. Now, we are working on that. So some of the things we've done to improve our patient engagement and increase that return rate, so we get a richer data coming back and a wider representation of the cohort is some of our patient engagement. And Dr. Singh showed a little screenshot of the webpage, patient-facing webpage that we've created. His team have been brilliant. They love a camera. So we've done some videos where they explain, the nurses explain to a patient at the top of the prom. So it's embedded in the prom. It's the first thing the patient sees. They open the link. They see one of Dr. Singh's nurses, one of the CNSs, who tells them what's going to happen in the service. So it's really important that the nurses and the team are the ones to say, you'll come and see us. Don't worry about stuff. And it's really nice and personal. We've embedded those in the website with some frequently asked questions, and we've put all of that patient engagement information through, and we've started to check that with current patients going through. We've got some patient representatives that are helping us shape that, and they're actually doing some patient stories, which we're hoping to share very soon, on their story of their interaction with the fracture liaison service, which is really powerful actually, because they do talk around those things that Dr. Singh mentioned, their confidence levels and their fear of falling, their fear of going out, those things. And it really brings home what's important to the patients. So we're trying to make sure that we capture those things in the patient reported outcome measures and the patient reported experience measures so that we can learn from that. So that's a snapshot of the pilot data so far. Thank you, Dr. Singh.
Thank you, Christina, and I cannot thank you enough for, so I said, like putting that vision to action. So what does this knowledge mean to us? So if we look at this just these graphs, it just tells me I got a knowledge now. I got a knowledge how many people who all of them who had a fracture, and it's only if I have to manage only the severe extreme pain is 2 NHS numbers here. But if I see that I have severe pain discomfort as well, then another reach 15. So I can actually prioritize those patients. But if I look at the second graph here, who are not able to walk, I can still work around these 2 plus 20. But these NHS number might be the same because we're looking at cohort. And now if I've got a community team, and because there is KPI 6, which talks about the movements and physiotherapist intervention, and if I have enough resources, I'll use that with a value lens. Can you focus these 2 plus 2 patients? They might be same, or go for those which has got problem with the mobility. Okay, now we cannot do that at the moment, but we haven't got any therapists, but maybe a pain team or a community team. But what about anxiety levels? They might be the same people who are living with a very high anxiety now. I'll link with the faculty team, other teams. Let's work on this. And they might be the same patients again, who are at a higher risk of coming to the hospital. And this is where we can clearly work with other 6 goals teams. For example, goal 4, they have got anxiety. They got this. Can we work on this? Can we avoid this deconditioning? Self-care. So there are different types of graphs which we can create, but we use this data to knowledge for our routine practice. But this is the learning so far. But this slide talks about how we upscale this learning to all Wales. And having the national lead role does help sometimes because you are living with that burden. You have to do something different and something more. So as I said, like KIMTUF team, Swansea Bay, like every team is amazing. I just put some examples here. So KIMTUF team has already started with the radiological fracture identification. They want to do that. And now KIMTUF are also working on trauma, and I was going to introduce to Christina and see how we can learn on that. The standard referral pathways from Swansea Bay, how we actually fine tune our work smart. And so that takes us to the burden, what is in Wales. So rather than going into detail of this, the gross cost to the NHS Wales is £133 million. I'm not going to say I'm going to save all this cost by having this. We cannot stop people falling and fracturing. But can we do some cost avoidance? Can we avoid that loss of independence or away days from home for those individuals? By having that, the benefit calculations from Royal Osteoporosis Society, we know the cost of running fracture liaison services per year varies between 2.5 and 5 million. But even if you go for a top spec of 5 million, the annual benefits what we're looking for is 11 million. Now those benefits is cost avoidance, but this is acute, community and social care cost. And I've put a little bit of figures there that what this cost mean. These figures might slightly change because this is for all Wales. Individual health board have a different acute care cost for particular fracture. but they can calculate that by working with your finance colleagues. Now, obviously, government
Inder,
sorry.
Sorry. Just because we want to give the opportunity for people to speak, and normally our presentations would be 10 to 15 minutes, and I'm really sorry about this.
No, it's fine.
But you know, and I think some of the questions that are raised can actually highlight some of the points you want. Are there some key points that you just want to bring to the table now?
Okay.
And then we can just open it up.
Sure, I can take this up. So we have got a good support from the government. Now that is the Welsh FLS model, which work on the 3 priorities of promoting health, providing care by integration, and protecting refracture. And this is underpinned by the quality triology. Now this will be part of the quality statement. So, and I can share this model with them. This is what we have done in Wales as we speak now by having support from the value team and the 6 goals, where we got £1 million been used, and how to invest in the clinical nurse specialist. So that's the news which I think been highlighted previously. We have rolled over these services. It clearly tells us the targets for the next 12 months for us, what we need to do. So working particularly on DEXA scans. That's where we are with evolution. It's work in progress, it's improving and moving in the right direction. So these are the next step for the quality statements. Again, it will hopefully be approved by the CAPSAC soon, or First Minister, and that will talk out how we implement our bone health services in Wales, but in a step down approach, not forgetting high risk and dementia. These are our challenges. We need more money, more resources, and DEXA scan. And these are my tips, that the key part is partnership working and digital innovation technology use. So yeah, that's where we are. That at least if we have got a value in health principles, we got evidence, we got clinical expertise, and now we had a political support for this change. I think we can work collectively to say that let first fracture be the last and reduce the spiraling cost, and keep thinking that osteoporosis is a lifelong strategy and it's a treatment for lifelong. It's not going to go away. So thank you all. And
thank you very much, Inder.
Stop sharing.
You've made a fantastic case, and I think the extent to which we have to consider bone health is so important. That it's a public health issue, really, as much as anything. And I guess the question I have here, which is, so David Whaling has given us a question: is there a public health angle on this for better advice in improving bone health in the general public? And what's interesting is he's from digital and health intelligence. And so, what's the role then of digital and health intelligence in this? I think because of the scale of this, and how do we bring that? So the 2 questions there.
Well, Public Health Wales is on board. Public Health Wales is on board now. We in fact met them last week, and they're very, very keen to get involved. And obviously their focus is the more of a primary prevention, hence dementia, frailty, and doing the fracture risk assessment for those individuals remains the key. The high risk individuals, including all age group, remains the key because they might be on steroids and other medical conditions. So the second part of digital innovation, that's the key. And if I see digital part, I see 1 FLS services for Wales and 1 radiology RADIS system which identify the patients, but they naturally get added to the fracture lesion services database. And we start our journey from there rather than identifying ourselves. That will be a very difficult way to achieve that, linking one database to other. But even if we use the RADIS, and every radiologist, radiographer identify fracture and think of the severity of that fracture and get reported, it will be picked up. So that's way. But the second part, which Christina has put it out there, that's another digital innovation way, that how we measure the outcome measures and use that data to knowledge.
Did you have any questions?
Yeah, well, I was going to pick up on a couple of the questions that's come from the audience, if that's okay.
Sure.
Although you guys are probably the experts on the pronunciation of this, so I hope I do it justice. So from Gil Guki, we've got, given the low adherence rate to oral bisphosphonates and the time needed to follow up patients to check on adherence, what is the place for IV zoldronate? Yeah, 100% adherence at 12 months. Yeah. Is it just post-hip fracture, or should we use it more? And would that help with the benefits?
It should be used more, and we can easily use. It's not very costly, and the cost is about £3 to £5, and it's administration. And majority of those patients are in a hospital. But I think what we need to be careful with that is looking at the patient themselves. What is the background, the comorbidity burden? What type of fracture did they have? They are quite frail, and obviously, let's say somebody with dementia and a frailty and a hip fracture, and in the hospital, Zoll is the right answer. But somebody who is 55 years of age, only had a wrist fracture by slipping on ice, the treatment is different for them, because Zoll is for limited time period. So that's where the fracture agent services is one part of this. The second arm is the bone health or specialist bone health services, which take through the journey of those individuals. By all means, the zoledronic acid, the administration is better in Wales as compared to the UK. And, and I think that's the way forward to manage the bone health and frailty. So I'm pro for that.
Perfect. There's been a few questions, actually, everybody, in relation to some of the measures that you're collecting. And Christina, I think some of the ones that have been linked in with the PROM. So I'm going to round a couple of them up, if that's okay. So there was one asking if there's any data being collected about people who work and whether preventing fractures, and I guess that could sort of feed into the measures about return to work, etc., and helps keep people in their workplace. And then Larry in Powys was really picking up on some of the questions that she does in her role as an allied health professional frailty specialist, and some of the questions that they ask. And she's put that they do chat about physical activity and nutrition, but is there anything else that they could do as well? And I was really hit by the lifestyle questions that you're asking, the food, mood, movement, smoking and alcohol. That stuck with me. And I think that it links with public health, make every contact count, and all these different measures. And I think it's really interesting if you could elaborate a little bit more on that work, for maybe some questions or some shared working that others could look at.
Yeah, of course. So the lifestyle optimization was aimed at making every contact count, a little bit of prehab for cancer, but it has so many applications because it's automated and it doesn't take that resource. So it is really, really exciting stuff. And we've created a little bit of a demo of what that looks and feels like. So I can share that for circulation after with the people who've attended, so they can experience what a patient might go through to collect that data. The first question you asked, I don't really have an answer. We don't ask in the PROM whether or not a patient's in work. That is something that we would get from other sources of data. So it may be usually recorded clinically with the nurses. So that would come part of the case mix variables. It's not something that we record on the PROM, but it is something that we would need to consider with the part of the case mix variables of the wider piece of work for value.
That's lovely. And I think what you've all demonstrated actually is how things mature, and then there's more that you want to look at and more impact that you want to consider. Because obviously if we're getting upstream on this, then we've spoken, Indra, about the cost of social care, but actually, that independence of someone living in their own home is really valuable as well, isn't it?
And I think, for coming as a paediatrician, I'm always thinking about carers and the impact on carers, and Leslie Kay, from NHSE, has raised that as well. There'll be huge impact on carers, and is that something that you're thinking? Because there's a loss of work as a result of that, and is that a measure that you're considering?
Not at the moment, but that is something is on the table to do it. And we know the carer burden stress is a huge problem, and many of the time these carers, they're not living very close to those patients. They're living far away. So even if you get them on a call, So while using Attend Anywhere, for example, which we have trialed, it worked beautifully. That allays some of the anxieties for them. So anxiety is a part of a burden. But to measure the carer burden stress, I have always spoken about that in my lifetime, but I do not remember effectively using Zavid's tool or any other tool to measure the care burden stress. We don't do that. But in our medical sciences, we're not doing it. We are aware of it, but that's not effective part of our care plans. We acknowledge it.
And that sort of leads just on to just sort of a question, because Darzi in his report has really raised this issue about integrated care and thinking out of the box, and how do we get more people involved and earlier interventions, which then is a societal issue, speaks back to public health. And is that something, again, that you're thinking about, you know, is there workplace issues that we could think?
So Nick, we are definitely thinking on those lines. But the measuring for sake of measuring is something which I'm not trying to do in life, because I haven't got enough resource or enough energy or time. If I measure that, what will I do with that? So I think it's in our, if we actually mentioned this in our quality statement as well, but it's just something for the sake of measuring and not doing anything is something I'm trying to avoid. But if we have got enough pathways in place where we can measure and do something about it, but then yes, definitely, yes, it should be part of it. It's on the table. Christina, I'll let your views.
So yeah, just to say, we in Nair and Bevan have collected care burden in the past in Parkinson's and dementia projects, and we've measured that successfully. And some of the things we were able to see is that when the care burden gets really high, it ended up in an admission, and we were able to use that then to try and look at admission avoidance stuff. So yeah, really interesting. I can't go into too much detail because I didn't prep for that today. It's just
no, that's fine. But I think that goes to our wider discussions, doesn't it, Christina, about how all of these different specialties and segmentations of work actually do come together, and we can learn across and gather that additional value from them. And so coming from the same area of work as you, these kind of return to work measures, the care burden measures, there's something that as our teams can look at to demonstrate, you know, this, again, it's not a do nothing. We need to look at this so that we can prevent readmission or complication of other comorbidities, but also I think about how we do spread our work and share our work with primary care community, housing, social care, and how we bring them into the value equation, you know, fitting with the fourth pillar of social value. Again, it's as we're maturing, as we're learning, but for clinicians, as much as we can automate that data coming through so they can take and use what they need to without being overburdened by needing to know all of it. And then it's down to some of us to how we can use that information to help shape the system, isn't it, I think?
Yeah, couldn't have said it better myself. Yeah, definitely. I think there's a lot to be said around data-enabled decision-making and data-driven decision-making. It's about having enough data to make valid decisions and then measure those and the impact on those and then make more decisions. But yeah, don't decide before you've measured would be what we see.
Absolutely. And what's been absolutely lovely to see is different people sort of letting our other viewers know about what's going on in their areas as well. So, you know, hearing from Hilary and John talking about the great work that's taken place in Powys and really great opportunities to collaborate. Inda, you know, on your second slide was all the people that you've been collaborating with. And that goes across our own organisations, across Wales. And I think every opportunity that we can take to learn from each other, openly share. Most of what we're trying to solve is the same. We often talk about this in value-based healthcare. There's always an element of localization, but we all get greater value, and the patients of Wales and populations of Wales all get greater value when we share. And so, you know, please do take a look at the links that people have shared. And Christina, if you can share those demos and any other information, and really a plea to other people who are watching as well, you know, reach out. These are open communities and we're all really keen to learn from each other. Nick, over to you. I think we've got a couple more questions coming if we've got time.
Yeah, I think we've got just a couple more minutes. And I think this just feeds into it's that data-driven processes, and obviously it requires then patient input. And you mentioned and this is raised by Raja Biswas, who's saying, there's a PROM rate of report rate of 40%, and is how do we optimize that? But I think that's across the whole of healthcare, isn't it? And this is a challenge we all face. Do you have any sort of ideas?
I'll let Christina talk on that.
I think our PROM completion rates vary on service to service, and what we know is when you engage the patients in understanding why we collect our patient-reported outcome measures, you get better engagement. It's not rocket science. If patients know why you're asking and what you're going to do with the data, but then they need to have trust that you're going to do something with the data. We hear all the time when we do patient engagement stuff that, oh, you did listen then. When I filled that form in, you did look at it. Because very often, not necessarily in health circles, but just in life, how often do you fill in things and think you didn't read what I said? We talk a mantra of, if you're not going to pay attention to the answer, don't ask the question. So we really need to think about the questions we're asking of our patients and explain why we ask. One of the frequently asked questions we get, and it's actually on the patient facing information pages, so we can direct patients to a single source of information, is why do you ask me the same questions over and over and over again? But we need to explain that it's about measuring the difference in points in time. If we ask you at the end of your treatment how you felt at the beginning, you'll either have rose-tinted glasses or you'll think you were horrendously ill. But we need to ask at each point in time to show that. So those kinds of things, the only way we'll get it better and to increase the completion rate so that we get richer, more comprehensive, more representative data of our cohorts is patient engagement, is to let them know why we're doing it, what we're doing it for, how we're acting on it, upfront, be honest, and that's how we'll increase those rates.
That's a great response. Sorry, we've only got the 1 minute left. Go ahead, Dee.
No, I was just going to say, and that's where the teamwork comes in, isn't it? Right. So we need the clinicians mention it in their clinician time, and we need to be thinking about our administrative roles and how we mainstream it into the communication that we give the patients, so that it's not seen as something that's only mentioned once, and that it becomes mainstream and used to what patients are having.
Yeah, definitely.
Wow. You know what? The time has flown by, and I certainly am going away this Friday thinking about my bones and what I do need to do to make them a bit healthier. So thank you guys, and I am more than looking forward to meetings with my own team, which are set for Monday. So we know this is running at a pace in there to really see this go out across Wales. Nick, what's your final comments as well?
Yeah, and we didn't even get into sort of that this is a life course thing, and that we need to be optimizing bone health and behaviors around bones earlier on. But that's a separate issue. That's because I'm a pediatrician. Really, thank you very much, Inda. Thank you very much, Christina, for your presentation. You make a fantastic case. And so our next one is next month. We still have a December one coming up. So value, and unfortunately, I don't have a list. So I think it's going to be a deep dive into high value, high impact pathways. I'm not sure what Gareth means by that, but we'll find out on the 6th of December. So thank you very much, and all the very best to everyone, and have a great weekend.
Have a great weekend. I'll see you all soon.
Thank you.
Take care.
Thank you, everyone.